Morning, respected chairman, latest chairman, sir, VC sir, co-VC sir, principal sir, deputies, colleagues, and dear students. Today we mark the 1 year of postgraduate combined rounds, and we have planned actually a special PGCR to mark the occasion of 1 year of PGCR, but due to the unavailability of dates due to the preparation of NET, we have postponed the university special PGCR, and I requested Dr. Suraj to please do this PGCR, 14th PGCR for the nephro patients. So there are some facts about the kidneys that though the kidneys make 0.5% of body mass, but they receive around 20 to 25% of the cardiac output, that is around 1.2 liter per minute, and to produce only 1 to 1.5 liter of urine. So how important are the kidneys for our body? And they are the very efficient water reabsorber, and they absorb around 99% of water and only let 1 to 1.5 liter of water get passed through the kidneys, so they prevent dehydration also. There are 1 million nephrons in one kidney, and kidneys work efficiently till they lose around 75% of their nephrons or their function. Even when they are 50% of function is lost, there is no symptom. So we have to be very cautious about the renal diseases and to get our renal functions checked timely in those patients where the indication is there. AKI carries a very high mortality, that is up to 67% in critically ill patients. Drug-induced AKI are very common. We know that in our setting, in our patients takes a lot of herbal and alternative medicines, and they are the main causes of AKI in our setups. And there is a word called renalism. Sometimes society and even the doctors discriminate against the kidney patients. So we should not do that because their life is always miserable. So our chairperson for today's session is HOD Nephrology, Dr. Suraj Godara. And I like to invite Dr. Arun, DM resident from nephrology, to proceed further.
Good morning, everyone. I am Arun from Department of Nephrology. So today we are going to be discussing about the acute kidney injury. So we have divided. This is a very big topic. So we have divided it into two parts. So today we will be covering mainly the introductory aspect, the common features of acute kidney injury, the etiology and the impact of the acute kidney injury. We will also be covering the pregnancy related aspects of the acute kidney injury. In the second part, we will be covering the rest of the things, including acute kidney injury in specific scenarios and the management of acute kidney injury. So first of all, as already told, so kidneys process a lot of blood out of proportion to their mass. They are also very efficient. So in this case, we also have to appreciate that they take up about 7% of the whole body oxygen consumption. The cardiac output they receive is around 1200 ml per minute, of which around 650 ml per minute is the renal plasma flow, which varies as per the hematocrit of the patient. And of this 650 ml, around 20-25% of renal plasma flow is ultra-filtered across the glomerulus. This is known as the glomerular filtration rate. So this is a brief outline of the major chunks of the various functions that kidney does in the body. So we can classify that as first as the regulation of acid-base and electrolyte balance, the regulation of blood pressure and blood volume by the renin-angiotensin-aldosterone axis, the endocrine function which are involved with the calcium and phosphate metabolism, erythropoietin for production of blood, and renal. The excretory functions include the excretion of nitrogenous waste products, various drugs that the patient takes, and as well as the metabolites of various compounds. So this, you might remember this diagram from somewhere. So we have seen this is what a nephron looks like. So as already told, each kidney has around 1 million nephrons. Each nephron is capable of working independently. So nephron is the smallest functional unit of the kidney. So the total kidney function can be thought of as an addition of all the nephrons individually. So these are the major parts of the nephron. So we'll start with the Bowman's capsule. It is the structure that covers the glomerulus. So what is the glomerulus? It is the tuft of capillaries. So the major function of the glomerulus is that it is going to receive all the blood, of which around 20-25% as already discussed will go through it. Also the glomerulus is also selective in what it is going to allow through. So most of the larger molecules such as proteins, specifically albumin, are not going to pass through the glomerulus. So it also follows when you have a glomerular disease, you are also more likely to get proteinuria in the reports. So next, the urine then proceeds from the glomerulus, it is ultrafiltered, then it proceeds along this path and comes to the tubule. The tubule can broadly be seen of as in three parts: proximal convoluted tubule, loop of Henle, and distal convoluted tubule. So what we have to overall understand that the main function of the tubule is reabsorption. So of all the substance that is filtered through, many of the substances, so most important part of the reabsorption is going to start in the PCT, the proximal convoluted tubule. So 2/3 of the sodium, the water, almost all of the glucose and amino acids are going to get absorbed at this place only. Then the urine is going to proceed to the loop of Henle. The loop of Henle also does further absorption of salt and water, and also very important, if we can remember the aquaporin channels, they are active in the loop of Henle, and this is also where the loop diuretics are going to act. Then from the loop of Henle it goes further into the distal convoluted tubule. There is active reabsorption of solutes here. So usually water will not get through the loop of the distal convoluted tubule, it will not be reabsorbed. However, ADH can act here, and in that scenario even water reabsorption can occur from the distal convoluted tubule. Also, the distal convoluted tubule forms a part of the juxtaglomerular apparatus, which we will discuss ahead. Then the urine goes to the collecting duct, and all these collecting ducts join to form the renal pelvis, and the urine goes into the bladder. So going to two very important aspects when we are trying to understand the pathophysiology of acute kidney injury. First is the renal autoregulation. So the BP, even in a normal patient who is not hypertensive, is going to vary throughout the day. However, from what has been seen that from a mean arterial pressure of around 80 to around 180, the kidney manages to maintain almost a similar glomerular filtration rate. So how does it do it? So the main mechanism that kidney employs to do this is called the tubuloglomerular feedback. So we just talked about the juxtaglomerular apparatus. So one part of that is the distal convoluted tubule, the other part is the macula densa. So as you can see, the glomerulus, it is located close to the afferent and efferent arterioles. So the macula densa is going to sense the fluid and solute load, mainly the sodium load that is coming into the afferent arteriole. If the perfusion drops or if the solute load is less, it is going to cause vasoconstriction. So depending on the solute load, whether it is less or more, it is going to vary the lumen of the afferent and the efferent arteriole to maintain somewhat stable GFR. However, if we give drugs that are going to affect its sensing, or if the patient is having very low or very high BP, this mechanism is going to fail, and that is when you start to get a drop in the GFR. So one more very important function of the kidney is the volume and blood pressure control. So this is mediated by this axis, we are all familiar with it. It is called the renin, angiotensin, aldosterone, named after the three most important hormones involved in this. First is the renin. Renin is secreted from, again, the juxtaglomerular cells of the kidney. Second is angiotensinogen, which is then secreted from the liver. The active metabolite of angiotensin is called the angiotensin 2. Third is the aldosterone. So how does this act? So first of all, the kidneys again are going to sense a drop in blood pressure or drop in fluid volume or solute load. The kidneys are going to produce the renin. That renin is going to act on the angiotensinogen, convert it to angiotensin 1. Then angiotensin 1 is further acted upon by the angiotensin converting enzyme released from the lungs. Then it becomes angiotensin 2. So angiotensin 2 is the major metabolite, so it acts in two ways. So first of all, it is going to act on the adrenal glands, and there it is going to stimulate release of the aldosterone hormone. Second, it acts directly on the blood vessels, and it also causes vasoconstriction. So just to complete the circuit, the aldosterone then goes and acts on the kidneys in the in the loop of Henle and the ducts, and that is what we discussed. So there it is again going to enable reabsorption of solutes and water. So whenever you get a hypertension due to aldosterone, it is going to be mainly volume and solute mediated, not mainly due to vasoconstriction. This is the major part. So in this way, kidney is one of the organs apart from the brain and the heart that is able to auto-regulate its function. So if we understand this axis, we can also find where we can do interventions for hypertension. Can anyone tell me the common or first line drugs that we use for hypertension? ACE inhibitors. Okay. So where are the ACE inhibitors going to act on this level? Any other drugs? ARBs. Okay. So where are the ARBs going to act? They are actually angiotensin 2 receptor blockers. So they are going to act at the effector level, wherever the angiotensin 2 is going to act. What other drugs? Any other? Diuretics, yes. Which diuretics? So, mineralocorticoid antagonist. So, spironolactone, again, it's actually endothelin antagonist. So, that is why when you have a patient with refractory hypertension, when you stop this is the last step. So, when you stop the last step, you are more likely to get control. That is why spironolactone works even in refractory cases, and also it is the drug of choice when you have a case with aldosteronism. So, there is also one more class of drugs. Anyone aware of renin inhibitors? So there is a drug called aliskiren. The congeners also have come. So this actually is the rate limiting step, the step mediated by renin. But due to safety issues, it's not being used, but it is very effective. So moving ahead. So whenever we are going to get a patient with ADH, again sir, usually ADH is not active, but again if we go back here, it can act on the distal convoluted tubule. So more solute and water reabsorption is going to happen. So in that case, it will be volume and solute mediated hypertension. Yes, it is. Sir, in ADH, so it's predominantly going to be more of a water overload. So we in patients such as those who are having SIADH.
Any clinical syndromes?
Sir, in SIADH we are going to have ADH excess. So we are going to have water excess out of proportion to the solute absorption. So we are going to get a isovolumic hyponatremia.
Maybe you will do it later, but you need to explain it more to the surgical audience, because we see it not often, but sometimes we don't understand anything about it. We just know that the patient is passing large volume of urine, and then people come and say just CR, but we don't understand. So maybe at some stage.
So we come to the laboratory evaluation. So first of all, we are all familiar with the so-called RFT. We send it almost by default in every patient who looks to be sick. So if you were to be asked what is the one test that you have to be sending, so for almost all patients it is always going to be creatinine. So why creatinine? So creatinine is the most validated test. So creatinine is the most common test on which you are going to calculate the GFR. So creatinine is the best studies. Most of the definitions and equations are going to employ creatinine. Also, so when you are limited in creatinine due to some aspect, you can also use something known as cystatin C. It is a newer biomarker, and it is mainly validated for CKD, and the 2021 equation, there is also equation for cystatin C in patients where you think creatinine might be false. We will discuss where it can be. So urea. Sir, isolated is very costly. If our point of care machine, that EBG machine, it can be included, then the cost can be. So next is urea. So it is very important, never be too much committed to urea. It is always a complementary test, and if urea is very much out of proportion to creatinine, we should be thinking non-renal disease. Additionally, you might have always seen there is also something called as blood urea nitrogen. So how to derive it? You can just divide urea by 2.14 to get the BUN value. So then you can also measure the metabolic functions of the kidney, more relevant for chronic kidney disease than AKI, the calcium, phosphorus and PTH levels. We'll check the electrolytes. Of course, hyperkalemia is a very common complication of AKI, so it is very important that we always rule it out. So putting some emphasis on the blood gases. So it's ingrained in our brains that patient बहुत sick है, you have to send a ABG. So let us not make it a habit. So for most of the patients who are going to require only acid-base balance assessment, venous blood gas is going to be sufficient. Arterial blood gas is having much more risk of, there is more pain, there is more risk of complications, and also it is technically difficult to do. So when venous can give us enough information, we should not do arterial. Unless there is a respiratory component, let's say patient is on high flow oxygen, or patient you are suspecting type 2 respiratory failure, or it is a patient who is mechanically ventilated, where doing a ABG is going to give us an advantage. So next, moving on, urine examination is a must for every patient with renal dysfunction. So you will go for routine examination and microscopy, and ideally we should always go for a quantification of the urinary protein whenever we see a proteinuria. So best way is of course 24-hour urinary protein measurement, which might be slightly cumbersome to do. So we can go for the albumin creatinine ratio or protein creatinine ratio. We can also employ the urinary clearance of creatinine whenever we are in doubt when the RFT is not matching. However, again it will require a timed collection and is difficult to do, so not commonly done. Then, whenever we are going to suspect primary renal disease, or whenever the acute kidney injury is not resolving, typically after 2 to 3 weeks, then we will be doing specialized investigations such as ANCA, ANA, C3, C4, ASO, etc. And overall, whenever we are in doubt, whenever we cannot establish a diagnosis, renal biopsy is the gold standard for diagnosis of all renal disease. So now we will just get a brief idea of in which patients is the lab parameter not going to be reliable. So essentially, for as far as creatinine is concerned, any patient who has a lower muscle mass is going to have a lower creatinine. Who is the patient? So any patient who is of older age, in general females, and those who are completely vegetarian and a low protein diet. So it is estimated that most of the people in our country are only consuming around 0.6 gram per kilogram per day of protein, which is far below the recommended standards. So in Indians, the actual GFR may be lower than what is measured by the equations, which are not exactly validated for the Indian patients. So then, of course, on the opposite side, of course, any patient who is having a higher protein or meat intake is going to have a falsely high creatinine. Then there are drugs. So these drugs competitively inhibit with the creatinine function. So it's derived for creatine. So they falsely elevate the creatinine levels, although the GFR has not really dropped. Then about falsely low urea. Urea is derived from the. So they are. So cimetidine specifically has this. Ranitidine is not that significantly going to impact. Yes. It's not. So any patient who is going to have liver damage, malnutrition, or overhydration is going to have a low urea intake, because in these patients the nitrogenous waste products themselves will be very low. So on the opposite side, so any patient who is going to have a high protein intake, specifically patients who are going to have a GI bleed are going to have very high urea. So in these patients, the bun to creatinine ratio can be higher than 30. And if we have any patient with such findings, we must rule out GI bleed. Also, there are some drugs who can cause falsely high urea, such as corticosteroids and tetracycline. So this.
So if a person with normal kidneys is taking high amount of protein more than required, then also creatinine will be abnormal, or will it be just high in the normal range?
It will be nearby the higher upper limit of normal.
But the kidney would still kind of keep the creatinine within normal range.
You have told that creatinine is the best risk indicator of renal function. Creatinine estimation
Creatinine
is the best. Sometimes the urea level is high and creatinine is normal. What are the causes of that?
So whenever we have a urea that is very much out of proportion to creatinine, so first of all, the primary renal disease should be lower on our list of differentials. First, we'll think of pre-renal AKI. So in pre-renal AKI, let's say because of dehydration or
Because of dehydration or hemoconcentration, urea level may be high, but the
creatinine level will not. So now coming to the urine analysis, we'll not go into detail. So what are the most important points in the urine analysis that we need to focus on whenever we are going to interpret acute kidney disease? So of course it's the color. So any patient who is going to have a classical muddy brown urine is the classical feature of acute tubular injury. Again, if we are specifically some patients where renal tubular acidosis there, we look at the pH. We should of course always look for the protein and try to quantify the proteinuria if it's there. Then we'll look for the red blood cells, WBCs, and specifically for RBC and WBC casts. The casts are much more important than the RBC, WBC themselves. And whenever we are suspecting a urinary tract infection, bacteria, and subsequently the culture should be done. Going ahead, so this is slightly difficult to understand, so we'll try to simplify it as far as possible. What are the major urinary profiles in acute kidney injury? So we by default send urine, we look at the WBCs, maybe we'll look at the RBCs, but we don't always interpret it in the way that it should be done. So urine routine examination is also termed as liquid biopsy. So a well done urine examination can reasonably get us to the diagnosis in a very low cost. So what are the major profiles? So first is the acute tubular necrosis, now called as acute tubular injury. So there of course, so if we had just discussed, so it's the tubules that are involved. So the proteinuria obviously is not going to be very high. So you have absent to low proteinuria. Then it's the necrosis of the tubules. So what are you going to get? Tubular epithelial cells. Additionally, you are also going to get the cast, the epithelial cast or the granular cast. So in specific cases, let's say for example, it's a case of rhabdomyolysis. So you will have myoglobin directly causing the injury, and you may be able to see the cast itself in the urine examination. Also, you can have acute urate nephropathy. You will be able to see the uric acid crystals. Then acute interstitial nephritis and UTI, will try to see both of them together. Again, the glomerulus is not involved, so proteinuria is going to be very little. So WBCs are seen in both, and many a time we see urine routine examination, WBCs बहुत सारा आ रहा है, must be a UTI, we give antibiotics. Sadly, in that patient, the antibiotics might be the cause of the WBCs in the urine, because that is a classical feature of acute interstitial nephritis. So in the absence of symptoms or culture positive, you should never ever label a urine examination as being positive for urinary tract infection. So you are going to get lot of WBCs, and occasionally you can get RBC and WBC casts. In UTI, it is very important, you will get RBCs and WBCs, but they are going to be isomorphic. So this is just because of the infection, so they are not going to be deranged when they are passing through a membrane, so they are going to be morphologically normal. And of course, if you have culture positive, you have to label it a urinary tract infection in the clinical context. So then this is what we have been studying since undergraduation. So we know nephrotic syndrome and the nephritic syndrome. So this is just stable. The urine examination reflects exactly that. So in nephrotic syndrome, the proteinuria is going to be very marked. So if you quantify it, it's going to be more than 3.5 grams per day. In nephritic syndrome, usually it is less than 1 gram per day. So again, these are predominantly glomerular diseases. So whenever a RBC is going to come through the glomerulus, it is very highly likely that it will get damaged, because normally the glomerulus does not allow a lot of RBCs to go through. So you are going to have dysmorphic RBCs. Now we are all aware that in nephritic syndrome you get more RBCs, so the number is going to be much higher in nephrotic syndrome, but they can be seen in nephritic syndrome, but they can be seen in nephrotic also. There are other features also, but they are non-specific and we should not focus too much on them. These are the main differentiating points. So now we'll come to our main topic. So we have understood the basic physiology of kidney as it pertains to acute kidney injury. We have got some idea of how to interpret the renal function test. Now we'll go to actually defining acute kidney injury. So I have taken this opportunity to clarify to everyone. So what is the definition of every part of renal injury? So it is mainly based on the duration of the disease. So whenever you have a kidney injury lasting hours to days, it will be termed as AKI. When it is days to week, it will be termed as RPRF, rapidly progressive renal failure. When it is lasted for more than 1 month, the new term introduced for that by KDIGO is acute kidney disease. When it is going to last for more than 3 months, it is going to be termed as chronic kidney disease. The term ARF or CRF are no longer to be used. So how do we numerically define acute kidney injury? So the previous criteria was rifle, it is no longer used. We will be going only for the KDIGO 2012 definition.
What is KTIG?
KDIGO is the standard body for guidelines related to kidney disease in the world, and these guidelines are considered as
What is the full form?
kidney disease improving global outcomes. So, how do we numerically define AKI is when you have a rise in creatinine more than 0.3 in 48 hours, or a 50% rise above the baseline levels in the last 7 days, or specifically patients who are in ICU, commonly this is seen when the urine output is less than 0.5 ml per kg per hour for 6 hours. Going ahead, so what is AKI on CKD? So in any patient where you do not have a baseline value, this should always be kept in your mind. So if there is a patient who has already been known to be CKD, if they have a rise in the creatinine and they are meeting these criteria, that is what is called as AKI and CKD. And additionally, we should also keep into account that patient who has a very high creatinine will have some variation as per the diet he has taken. So those variations should not account for AKI. Urine output will be more appropriate in patients with advanced CKD. So this is the continuum. So AKI essentially a subset of the AKD, the first 3 months and the disease lasting more than 3 months. This is the continuum of renal dysfunction. AKI can go into AKD, can go into CKD. So we go to the staging of AKI. So if you have seen a reference, we often write these stages. So most of the time we do not pay a lot of attention to the staging itself. So first, what is stage 1? Stage 1 is that when a patient has just met the definition for acute kidney injury. So the creatinine is 1.5 to 1.9 times the baseline, and the urine output criteria has been met for less than 12 hours. So the minimum is 6 hours, but it has been met for less than 12 hours. Going ahead. In stage 2, when it is going to be more than twice the baseline, but less than thrice the baseline. And the same urine output criteria, but now it is between 12 and 24 hours. And stage 3, very easy to define. Any patient who is on RRT is by default stage 3. Any patient who had a normal creatinine and now has creatinine of more than 4 is going to be stage 3. And of course, stage 3 rise more than 3 times. And on the same thing, this is a little bit difficult to remember, but any anuria for 12 hours or the urine output less than 0.5, it goes to 0.3 for 24 hours. That is the criteria for stage 3 as per urine output. So these are the major patients where urgent nephrology reference should be given. In these patients, because they might require urgent intervention.
What is anuria? Is it total absence of urine output?
Sir, in the obstruction context, anuria would be...
Obstruction, yes. In the context of kidney injury or kidney disease.
So in the context of AKI, it is still absence of output. In the context of AKI, it is
Zero. Earlier definition that less than 100 ml in 24 hours.
That's for not really for it. That's when you have a longer term of the illness. So we are not trying to wait for 24 hours. So now we go to the chronological evaluation. The current limitations with these definitions, the current limitations with acute kidney injury. So initially when you get an acute kidney injury, you have a rise in creatinine, but the rise in creatinine is going to lag behind by 24 to 48 hours. In the meantime, you are getting kidney injury, but you are just not able to pick up on it. So this gives to the concept of using the novel biomarkers. So these biomarkers are stipulated to be positive within the first 8 hours itself, and in that case you will get the earlier indicator, and you can possibly do an intervention before the creatinine is actually risen. So cystatin C is itself is a marker as we discussed, but it is more validated for CKD rather than AKI. The other ones that are in development are the neutrophil gelatinase associated lipoprotein and GAL. This has already been incorporated into some guidelines such as the latest HRS guidelines. More than 220 is the cutoff for intrinsic kidney disease. And the other ones are also in study. The IGF BP7 is the one that shows the most promise for AKI per se. Very important, all these biomarkers are only going to be positive in intrarenal injury. So that gives us an additional advantage that it will not be positive in prerenal AKI. So we'll briefly just get an overview of the pathophysiology. So due to various reasons, the kidney is getting an injury. You're getting tissue damage, again leading to hypoxia, or you can have direct damage by the nephrotoxin. You get endothelial activation and inflammation. So the damage mediated then causes more reactive oxygenation species and eventually cell apoptosis and vascular dysfunction. So this is going to have systemic effects. We'll get a broad idea of where the complications are going to happen. So in the brain you are going to get the uremic, so-called uremic encephalopathy, although urea is not now considered to be the main toxin involved in this. We still don't know what is exactly the toxin. So in the heart you are going to have volume overload. Very severe cases you can get uremic pericarditis. Gut, you get the symptoms, you get nausea, vomiting, you get loss of appetite that is going to lead to malnutrition. Liver again you get congestive hepatitis and you can get intrahepatic cholestasis. You can have a bone marrow involvement causing dysfunction, and in lungs you can have more chances for infection as well as volume overload. So of course any patient you are seeing with AKI, we must rule out CKD, because CKD is the diagnosis that is to be approached very differently from a patient with AKI. CKD with the 3 creatinine that was 3 months back probably is not very urgent, but AKI who had 1 creatinine now 3 requires very urgent intervention. So the main features that occludes will be very small and scarred kidneys. There are exceptions like diabetes, polycystic kidney disease, etc. The mineral bone disease, so hyperphosphatemia can be seen in AKI and CKD, but low calcium and high PTH can be seen in CKD only. But we also should look for other factors that might influence them, such as acute pancreatitis. And unexplained anemia, specifically normocytic normochronic anemia, is a marker for CKD. So I would like to end this section with these 2 images. So first, that everyone should know who is dealing with critical ill patient. First shows a hydronephrosis. This is a patient who is going to require urologic intervention. And second is a patient with small scarred kidneys. We can use point of care in the emergency. We can diagnose, pick up at least these 2 profiles very quickly. Thank you. I would like to call Dr. Tapas.
Sorry, but acute kidney injury, on ultrasound the kidney would appear normal. Yes. Will there be some kind of
sir, except hydronephrosis, all causes are normal.
Everyone, good morning. August House. We'll be dealing with scope, impact and etiology of AKI. AKI is a significant contributor of morbidity and mortality, and its incidence in the hospitalized patient is 0.4 to 18%, which may rise up to 50% in ICU patients. In outdoor, it accounts to 1 to 5%, and overall hospital admission, it accounts up to 4%. Its incidence is increasing and is projected to rise further as the demographic of the patients admitted is progressively worsening due to comorbidities and chronic illnesses. The impact is mostly for cost related to treatment, and adverse outcomes are due to prolonged hospital stay and progression to chronic kidney disease. Mortality alone attributed to the primary causes causing AKI is 15%, and in critically ill patients it may rise up to 80%. Incidence is higher with people with low eGFR less than 15 ml per minute per 1.72 meters square or on dialysis. The major determinant of outcomes is the primary disease. It was a large-scale study done in Europe in mid-2000s. AKI CKD continuum, as the AKI is also known to progress into CKD, it itself carries a 8-fold higher risk, and if dependent on dialysis, the risk increases 28 folds. Up to 15% of AKI follow-up patients may have some degree of renal dysfunction at 5 years, and older patients with heart failure, hypertension, multiple recurrent episodes of AKI requiring albumin transfusion during admission they also call for higher risk to progress into CKD. The risk factors are subcategorized in mainly three parts related to patients, drugs, and procedural. Sepsis is one of the important risk factor. Elderly patients, especially more than 65 years of age, diabetes, pre-existing chronic kidney disease, liver failure, hypertension, and drugs such as NSAIDs and ACE inhibitors and ARBs, plus antibiotics such as aminoglycosides. In procedures involving cardiopulmonary bypasses, surgeries involving aortic clamps, solid organ transplant, liver and kidney, and percutaneous interventions using IV contrast. What are the common causes of AKI that we can think in IP and OPD basis? Anyone, please?
So, suppose a patient has suffered AKI.
Yes.
Now, with conservative management and maybe with dialysis, it has reversed back to normal. You said this patient has a high risk of developing CKD.
Yes.
In this time, is there any intervention available which can reduce that risk?
Sir, if we treat the primary cause, mostly primary cause is pre-renal. If even in the renal causes we reduce the insulting agent, then we have higher chances of saving the kidneys.
You said most common cause is sepsis.
Yes, sir.
Obviously, we have controlled the sepsis. So, this patient still, does he or she carry a higher risk of developing CKD?
So we'll see that there was a study in Indian context that within a 1 month, if the recovery is done, then it has a fair chances that it will be saving the kidneys. Common causes, anyone please? Okay. Acute tubular necrosis is one of the most common cause in hospital settings, and just to stress that the major chunk is due to acute tubular necrosis, we have incorporated this. The main causes are divided into pre-renal, renal and intrarenal. The pre-renal aspect includes the volume depletion, which may be due to shock, hemorrhage or decompensated heart failure, drugs and major vasculature congestion, venous congestion and arterial occlusion. The clinical profile will be including diarrhea, persistent vomiting, bleed, hypotension will be a clinical finding, tachycardia, reduced tubular venous pressure and skin trigger with dry mucous membrane. The renal causes include small vessel diseases of kidney vasculature, thrombotic microangiopathy most common, glomerular diseases such as lupus nephritis, post-infectious previously called as post-streptococcal glomerulonephritis, anti-GBM diseases, vasculitis. History compatible with glomerulonephritis such as hematuria, pain in bilateral flanks, lower pain abdomen, and even pulmonary renal syndrome are more likely in conjecture with glomerular diseases. Acute tubular injury, which owes its most common causes to ischemia, followed by infections, and other causes such as toxin, myoglobin, antibiotics such as again aminoglycosides, chemotherapy, and cystitis usually does not cause AKI unless the bladder is compromised, and pyelonephritis itself causes because it leads to damage to renal parenchyma. Acute interstitial nephritis due to viral infections and drugs such as penicillins and NSAIDs. How to differentiate renal and pre-renal? Though we have novel biomarkers as discussed previously, we can also discuss from history. Volume loss will be a predominant history in pre-renal causes, while in intrarenal there will be history of drug intake or toxin. The clinical feature will be of hypotension, while there is no specific sign or symptoms included in renal causes. Amongst the lab values, the 1 by creat ratio will be more than 20 in pre-renal causes, while it will be less than 20, usually less than 20, because it rises due to proportion to vasopressin action. Hence, therefore, it's more than 20 in pre-renal causes. Sediments might be flu hyaline cast seen in pre-renal causes, whereas muddy brown cast will be seen in the renal. Urine osmolarity will be less than 350 in the renal because the concentrating ability is lost, therefore low osmolarity. Proteinuria might be seen in pre-renal, while it will be seen in mild to moderate range in intrarenal or renal causes. And the fraction of excretion of urea and sodium will be more in the renal as compared to renal, pre-renal, because again the tubular function is lost, therefore the ability is decreased. And novel biomarkers, as we have previously discussed, are under study and mostly for renal, but offer good choices to differentiate between pre-renal and renal.
Stay on.
Yes.
So we see this dilemma in post-surgical or surgical patients very frequently. These urine tests which you have mentioned, so they are quite discriminatory. Do you suggest that when we suspect and when we want to call you to decide, at that time we should send urine for all these estimates, or we should wait for the
So I think we should wait. Amongst the post-renal causes, one of the important factors is until the obstruction is involving both kidneys, or there is absence of a kidney, or as happens in post-transplant patients, the functional kidney is obstructed, the AKI will not happen. If either of these three happens, obstruction will take place, the kidneys will be obstructed, so AKI will take place. And bladder lesion will, however, cause of both the kidneys. And post-renal में we'll find the examination में, the history, hesitancy will be there, frequency, duration will be increased, lower abdominal pain, and visible hematuria might be seen in cases of calculus. In examination, we'll have bladder fullness, and on digital rectal examination, we'll have prostatitis. And drugs, like we have discussed pre-renal also, they induce the AC inhibitors, ARBs, and diuretics, and post-renal NSAIDs and anticholinergics are important for causing PKI. In the drug induced for renal causes, they affect the 5 compartments of kidney. Small vessel diseases such as NSAIDs, ACE inhibitors, ARBs, calcium inhibitors, and oral contraceptives. While in glomerular diseases, which predominantly leads to rapidly progressive glomerulonephritis, adulterated cocaine, hydralazine, and propylthiouracil. Acute tubular necrosis by amphotericin B, aminoglycosides, herbal drugs, Ayurvedic drugs people used to take without consulting the doctors, and acute interstitial nephritis by penicillins, cephalosporins, NSAIDs, proton pump inhibitors, and immune checkpoint inhibitors. Intratubular obstruction is caused by acyclovir, ethylene glycol, and NSAIDs. Here I would like to pay some special emphasis on NSAIDs because they act by affecting nearly all the parts of kidney, glomerulus, collecting ducts, and vascular supply, cause pre-renal and post-renal effects, as well as cause progress to CKT if used for longer durations. Some commonly drugs that we encounter from our practice, which are available over the counter, can anyone say the prevalence and incidence and etiological causes of AKI in Indian settings. This link is provided here for free access to this study. It included 3,700 patients, and amongst all the patients they were divided in 3 categories: medical, surgical, and obstetric, out of which the medical patients were around 86%, surgical were around 7%, obs patients were around 6%. And amongst the most common etiology from this multicentric study was sepsis, especially due to urinary tract infection, followed by tropical fever, acute gastroenteritis, and liver disease associated AKI. Then obstetric causes, purpura sepsis and APH, BPH, they were more common. In the biopsy, which was done in 580 patients out of 3,700 patients, acute tubular necrosis was primarily found, it has to rule out glomerulonephritis, biopsy is a gold standard. Amongst the other causes were acute interstitial nephritis, acute tubular interstitial nephritis, thrombotic microangiopathy, pyelonephritis, recessive glomerulonephritis, and diffuse proliferative glomerulonephritis. The outcomes at discharge, if you can see, the highest mortality was at the time of discharge. And 9 patients, around 800 patients had complete recovery, and 2,000 patients had partial recovery. But at the time of first one follow-up, the partial recovery of maximum patients occurred with minimal mortality. Only 20 patients more died from 400 patients. While at 3-month follow-up, there was no mortality. There was mild rise in significance of partial recovery, while the comorbidities of complete partial, it was seen minimal. I would like to take over to, I'd like to give over to Dr. Vaishnav. Thank you.
Good morning, respected teachers. Now I would like to take over and cover the pregnancy-related aspects of the renal system. And cover the pregnancy-related aspects of the renal system and the AKI. We will first discuss the systemic changes in the pregnancy that directly affect the renal system. Now, during pregnancy, the threshold for the arginine luciferase release, also referred to as anti-diuretic hormone, reduces. There is resetting of the osmoreceptors for the arginine luciferase release. There is decrease in the serum osmolality by about 10 milliosmoles per kg. There is increase in the plasma volume by 40 to 50%. In the beginning of the pregnancy, there is decrease in the systolic BP, diastolic BP, and the mean arterial pressure. The pulse pressure also reduces. The systemic vascular resistance reduces by 25 to 30%. The cardiac adaptation and its effects. The cardiac output increases by 30 to 40%. There is increase in the heart rate, and there is upregulation of the renin-angiotensin and aldosterone system and related resistance to the angiotensin. The anatomical changes in the kidneys they include: there is increase in the kidney size by about 1 to 1.5 centimeters. The kidney volume increases by 30%, and in 90% of the patients they develop the physiological hyponephrosis, which is.
So what is the reason for increase in kidney size in pregnancy?
So it is due to increase in the vascular and the interstitial space volume expansion.
Any hormone response of this? It is the estrogen which mainly volume, you can say it is about 30% because of the overall increase in the volume. Increase in kidney size is mainly because of the effect of estrogen.
The glomerular changes include: there is increase in the renal plasma flow by 40 to 65%. The GFR increases by 50 to 85%, and the vascular resistance is going to be reduced in both the renal and
What is the reason for decrease in vascular resistance?
So it is due to the effect of the relaxin and the nitric oxide.
Progesterone is pregnancy का हार्मोन ऑप्शन ज़्यादा ज़्यादा है. Progesterone is the relaxing hormone. Estrogen works on the kidney and the rest of the organs, ureters, blood vessels, everywhere. Progesterone which acts and which leads to the decreasing resistance, which leads to the decreasing blood pressure.
Now the tubular changes would be: there is normoglycemia with glycosuria, the urinary protein excretion increases, and there is decrease in the reabsorption of the uric acid and the amino acids.
You can explain all these things with the help of progesterone. Mainly.
Now this graph is showing the relationship between the renal plasma flow and the GFR. So during pregnancy, there is increase in the renal plasma flow which reaches the peak by 20 weeks, and then there is a gradual decline reaching to the normal in the postpartum first week. Then there is increase in the GFR reaching the peak at the 20 weeks following a plateau, which is followed by a gradual decline and comes to the normal pre-pregnant state at the postpartum 6 to 8 weeks. Now this table is showing the different lab parameters that are changed during the pregnancy. Now during pregnancy, there is hyperventilation which leads to the respiratory alkalosis, due to which there is increase in the arterial pH and decrease in the arterial PCO2. In response to this, the kidneys are going to excrete the bicarbonate, due to which the serum bicarbonate is going to be reduced. And the serum creatinine usually reduces. It is due to the increase in the renal plasma flow and increase in the GFR. There are no validated definitions for the diagnosis of AKI in the pregnancy, but certain criteria are being followed. The serum creatinine of more than 1.
Critical criteria is there. It is there. I read just last night. Go again and see. Check.
It's just there are no definitive ways. They are also saying there is some studies. There is no lot of data. So as you written, there is a right definition.
If the serum creatinine is more than 1 milligrams per deciliter, or there is a rapid rise of 0.5 above baseline in the 48 hours, is considered to be the AKI, indicates towards the AKI. The creatinine clearance by 24-hour urine collection is considered to be the gold standard. If the protein urea is more than 300 milligrams in the 24 hours, then it should be considered for the further investigations. Urine albumin creatinine ratio can also be used. What are the common causes of AKI? What are the common causes of pregnancy-related AKI in our hospitals?
Postpartum hemorrhage, antepartum hemorrhage, and HELP syndrome.
In the first trimester, second trimester से जाओ. Abortions नहीं होते क्या?
Abortion.
फिर
And second trimester में APH हो सकता है.
Septic abortion,
Septic.
perforations during the empty phase. Correct? They leads to sepsis, they lead to the you will come to the renal part of later part and the system. Whether an obstetric gynecology.
The etiology of AKI in the pregnancy. It has been divided into pre-renal, renal and the post-renal. The pre-renal includes the hypovolemia, which can be due to the hyperemesis gravidarum, postpartum hemorrhage and the antepartum hemorrhage. Then there can be sepsis, which can be post-abortal sepsis, porphyral sepsis or the urosepsis. Then we have heart failure and certain medications like diuretics and NSAIDs. The infrarenal includes the acute tubular necrosis, sepsis, preeclampsia, HELP, thrombotic microangiopathy.
What is HELP?
So HELP usually there is hemolysis, elevated liver enzymes in the platelets. It usually follows the
What is the cause for this?
So if there is preeclampsia, it is difficult.
Yes. Maybe we can tell.
HELP generally occurs when there is severe preeclampsia. It is generally due to the endothelial damage which occurs and leading to the multi-organ dysfunction, leading to the hemolysis, due to which the LDH increases. There is elevated liver enzymes and the low platelet count, leading to the HELP syndrome. Yes.
They are very similar in etiology as far as
Yes. Leading
we
to
should be
severe
aware, we should be aware
preeclampsia.
that protein is there in the urine in the early pregnancy, blood pressure is there, and should check for the blood liver counts and include liver inflammation.
Thrombotic microangiopathy, acute fatty liver of pregnancy, lupus nephritis and pyelonephritis. Coming to the post-renal, it can be hydronephrosis due to the compression with the gravid lupus, obstruction of the ureter due to nephrolithiasis and nitrogenic injury to the ureter. Now this table is showing us the timing of the AKI in the pregnancy. In the first trimester, it is usually the hyperemesis gravidarum or the septic abortion, then any cause of AKI that is prevalent in the general population. In the second and the third trimester and the postpartum, it is usually the hypertensive disorders that include the preeclampsia and the HELP, the hemolytic uremic syndrome and acute fatty liver of pregnancy. Now this table is showing the most peculiar differentials of AKI in pregnancy. As we can see, it is showing the comparison between the preeclampsia, hemolytic uremic syndrome, acute fatty liver of pregnancy, antiphospholipid and the lupus nephritis, out of which the antiphospholipid and the lupus nephritis they can clear irrespective of the period of gestation. The blood pressure can be raised in all of them, but it is markedly raised in case of preeclampsia and the HELP. The CNS involvement is usually seen in the hemolytic uremic syndrome. The fever is usually not present in case of preeclampsia and the HELP. The schistocytes in the PVF and the thrombocytopenia are a common feature for the hemolytic uremic syndrome. The liver enzymes can be raised among all, but they are markedly raised in case of acute fatty liver of pregnancy. The protein urea of subnephrotic range can be seen in all, but if it is a nephrotic range protein urea, then it usually points towards the lupus nephritis. The management includes delivery in case of preeclampsia and the acute fatty liver of pregnancy, while the rest usually involve the plasmapheresis, anticoagulation and the immunosuppression. We will now discuss the some Indian studies which have specifically looked at the pregnancy-related AKI. As we can see, the sample size is highly variable and the incidence is highly variable. It is due to the known uniformity in the definition as well as different screening and the referral practices. With more number of follow-up, we can see the more patients will have the complete recovery in the first month, and we will also see the long-term, the number of patients who would be ending up in the end-stage renal disease. For the evaluation and the approach, I would like to call Dr. Atul.
दिल्ली जाने के लिए वंदे भारत ठीक है, लेकिन कंबाइंड राउंड में एक्सप्रेस ट्रेन की स्पीड अच्छी
Now that we have learned very in detail about the various aspects of the AKI, so we would now like to see what are we going to do when we actually get a patient, let's say in the emergency, is going to have an acute kidney injury. So there is a patient who has been referred from outside somewhere with some raised creatinine value. So you, first of all, we want to rule out CKD. If there is CKD, we will approach it very differently. Then if you see they are meeting AKI definitions. If they are meeting AKI definition, so that is exactly where you will send tests, and that is where nephrology reference is warranted. Don't jump into giving a reference without doing the basics first. So if there is shock, if you have not corrected the shock, you have not corrected the renal part, there is no point, there is nothing nephrology is going to come and do. And if you have not given fluids to a hypovolemic patient and the nephrology department is telling you to do so, you have not done your diligence. So then you will see there is a renal cause, you give a fluid challenge. If the previous patient still doesn't make urine,
Which type of fluid you will give?
so it's anything but NS. So it's always going to be a balanced crystalloid, either RL or isolite or plasma light, but NS, not D5. Colloids are very limited benefit in these patients. Rather, if they have very low HB, so rather blood would be beneficial. Colloids as a first line are not to be used. There's almost no scenario in these colloids because there are specific scenarios where colloids would be used, like in patient who has a CLD or some other patient who has a very marked nephrotic syndrome. In them, where it's a distributive issue rather than shock per se. So in these patients, the oncotic pressure in the is very low. So the blood volume will be less. So even giving in them colloids will be beneficial. But for most of the patients, colloids are not going to be the answer.
Simple renal lactate or normal saline should be.
So always RL. NS is only for specific scenarios when we have hyponatremia or where we have let's say any evidence of raised ICP or when there is a liver dysfunction. Otherwise, it's always going to be RL or other balanced fluids. Yes, so there is very clear evidence behind this. So if they are not responsive, so that's when we are going to suspect an intrinsic renal cause. That will be a reference that the further evaluation will be done. We'll just end with a short case. We'll not try to find the diagnosis. We'll just try to see what all options should be entertained. So it's a healthy young female. She has come to us in the emergency with fever, vomiting and loose stools since the last 4 days. And she complains that she developed decreased urine output in the last 2 days. She has approximate urine output of 200 ml in the last 24 hours. She received some oral antibiotics and antipyretics. If you are working in emergency, you might be aware this is a very common clinical scenario. We don't know what antibiotics she was given, and we are not sure whether those are actually antipyretics per se. We don't know what she was given. We don't know anything else about her. She has no comorbidities. So she is hypotensive and tachycardic, and her creatinine, she has one creatinine report of 3.5. This is the let's say in a hypothetical scenario, this is the only information we have. So what are we going to think? Is this AKI or CKD? So let's consider the first 3 questions. Whether it's AKI or CKD, what is the cause, and what are the tests we would like to send. So can anyone give any suggestions? What it seems to be AKI or it seems to be CKD? What is the likely scenario here?
Most likely AKI.
Most likely AKI features.
Due to some vomiting or diarrhea, they will go to pre-renal.
So first of all, we have a clear trigger for AKI, and then timing. So we have a clear evolution. Why is AKI not a RPRF? We have a clear evolution. It's been in hours to days. It's not been like a week or 10 days. It's been within the last 2 days she had developed renal dysfunction. There is a clear-cut demarcation from where her urine output was dropped. She's saying 2 days पहले ठीक था. Yes, we'll just end. So we'll have, so it is, so just tell the answer. So it's AKI, and the cause could be the hypovolemia, the cause could be the drugs themselves, and now in this case, because it's been quite some time, she might have even got ischemic ATM. So we'll give her fluids and give allotropes as might be the requirement. I would like to end here. So this will be the part 2 we'll cover in the next session, and which will be planned later.